Good afternoon. This is Dr. Trustin Enicheril. I am the president and CEO of New England Telemedicine, and it's my privilege to speak to you this afternoon about telemedicine services at Millinocket Regional Hospital. I do want to take this opportunity to thank Bob and the leadership of the hospital for rolling out an innovative service that I think will help patients not have to travel long distances to get specialty care and as well as help the hospital financially. So I'm going to go through these topics very quickly. We're going to talk about the challenges faced by rural and critical access hospitals. We're going to talk a little bit about the history of telemedicine and how telemedicine can help hospitals capture revenue that's lost due to lack of specialty care. And we'll talk about the logistics about the services that we perform at Millinocket Regional Hospital and how to refer to us. So as you all know, there are a lot of challenges faced by rural and critical access hospitals. The payer mix is mostly government payers, which reimburse less than what is reimbursed for in urban or suburban areas. Medicare is reconsidering critical access hospital designations, and so some hospitals stand to lose quite a bit of revenue if that happens. Critical access hospitals and rural hospitals have a lack of specialty care and are geographically isolated. Telemedicine can't really help with all of these issues, but it can at least help with the bottom two. It helps with geographic isolation because it allows organizations to be interconnected. So it allows the physicians at my organization to work with the physicians at Millinocket Regional Hospital, for example. And it helps rural critical access hospitals that wouldn't be able to sustain a full-time cardiologist or a full-time neurologist to now have specialty care. So those MRIs or those CAT scans or those echocardiograms can stay local, and only the patients that really need interventions need to leave the local area. So it allows those healthcare dollars to be spent locally, and it helps support the community. And the American Hospital Association believes that most rural critical access hospitals lose about 20% of their revenue because they don't have specialty care. That's a lot of healthcare dollars. So what about the history of telemedicine? In 1990, telemedicine was very different than it is today. Equipment was very, very expensive. Processor power was very limited. Connectivity between organizations was very expensive. They had to lay down their own cable. Cloud-based computing didn't exist, and most of these projects were grant funded, so when the grants ran out, the projects died out. Today, things are very different. The cost of equipment has come down dramatically. Processors are incredibly fast. Connectivity is very cheap. We are a member of NETC, so we have a 20 megabit connection with every rural critical access hospital in the state. Cloud-based computing is ubiquitous. So we use an electronic medical record system where a medical assistant at Millinocket Regional Hospital could be inputting vital signs while the physician that's 2 states away could be dictating a clinic note. And finally, and most importantly, Maine state law mandates now that private payers reimburse for telemedicine services anywhere in the state. Medicare and Medicaid, also reimburse for telemedicine services if very specific criteria are met. Patients are in a rural setting, they're in a hospital or a physician's practice, and they're taken care of by a physician or a nurse practitioner or a diabetic educator. There are a number of very specific criteria that need to be met in order for Medicare to provide reimbursement, but the benefit here is that in a rural area, private payers and Medicare and Medicaid all reimburse for office visits. So, we could tell you a lot about what patients think about telemedicine, but I think the best thing is to show you a patient who actually has been taken care of at our practice.
I had a lot of problems with my blood pressure. It was very hard to bring it under control. A nurse, she says, "Oh, Inge, your blood pressure is way up high again. We have to do something about that." it takes the whole day away when you travel that far to see your cardiologist. When you come down to it back and forth, that's 7 hours on the road. That's a little bit too much. I'd rather go in my town. She came up with a telemedicine. She says, would you mind to try that? I says, right now I try anything and everything. I mean, at first I was a little tense about it. What is a doctor talking to me on TV for, you know? But that feeling left me real quick, because he was right there and he told me, if you have any type of questions, you go right ahead and ask. Sometimes it was almost like he is in the same room with you. I think he was a very nice doctor, because I had a lot to do with different doctors who sometimes were a little bit, got no time, but he did take time. It's almost like a dream come true. I like it. I really do. And I think other people would like it too. I would recommend telemedicine to anybody who's walking on 2 feet, because they're very good. I live in Waldoboro. I used to live in Kennebunkport, but my husband, he liked the cows. People don't like cows in Kennebunkport. They all come from Massachusetts.
So a little bit about our company. So we're a technology company which practices medicine. I think that's the best way to describe us. We're physician owned and managed, so we're not run by IT specialists. We're not venture backed. We're physicians that care about bringing specialty care to rural patients. And we leverage technology in order to improve access to care for patients in rural New England. We've been providing care at Down East Community Hospital in Machias, Maine for the past 2 years. And there we brought them cardiology care, pulmonary care, sleep medicine, neurology, endocrinology, hematology, and we see about 115 patients every month there in those specialties. And we run their echo lab, and we run their sleep lab, we run their infusion clinic. And so, we've had substantial increase in those services, because now the primary care doctors get those physician support. So the echo lab has seen a 500% increase in the number of echoes, because echoes are done very quickly and the providers get them within 48 hours. And sleep services have grown by about 300%, and so on and so forth for the other specialties. And so the idea is the need is there, and we kind of bring that technology to the hospital, so we make it easy for them to access those services. Our physicians are licensed in the state of Maine. They have DEA license in the state of Maine. We have malpractice insurance in the state of Maine. Our physicians are credentialed at our partner hospitals, so our doctors get the privilege of working with Synernet, as all of you have had as well. We can see into the hospital's EHR, PACS system, lab systems. We're members of Health InfoNet, so if patients have been discharged or have had CAT scans, we get that information. So, we really, when we see the patients in consultation, we really not only get the primary care doctors' clinic visits, but, our secretaries and our admins comb through Health InfoNet for discharge summaries and prior lab tests that are relevant to the specialty they're coming and seeing. So we have a lot of information from that patient's history. We use encrypted teleconferencing, so this is not Skype. The data is encrypted. We use hardened endpoints at the hospital and at our physician sites that are behind firewalls. And so the data is extremely secure. Our computers are encrypted. at the hospital, so they're very, very secure. We use telemedicine stethoscopes so we can listen to patients' hearts and lungs. We use special telemedicine otoscopes and dermatoscopes so that we can examine patients. Right now, we only provide outpatient care, so we don't provide emergency room care or inpatient care. The logistics of doing so are prohibitively expensive, and so we don't provide that care right now, but we do provide longitudinal outpatient care. So we provide care on the weekends where we see patients in the Poplar Street location, but if a patient were to call in during the week, we have our own nurses and medical assistants that can talk to our physicians and call in antibiotics if they're in a COPD flare, or order testing, or speak to the laboratory, or speak to a provider if necessary. In terms of insurance coverage, we're in network with 16 insurance companies in Maine, including Medicare and Medicaid. Every service we provide is covered by their insurance. Patients do have to pay their specialty copay and deductible, but it's no different financially than if they were to see a specialist in Bangor or in Portland. And how it works, the primary care doctor does a specialty referral if it's required by their insurance. We request that the PCP send over their clinic notes and relevant test data. We look at Health InfoNet, pull our own data for that patient, and we see the patients on the weekend at the Poplar Street office, Suite 1. We have 3 rooms that have been set up with telemedicine equipment. So the hospital has been wired for telemedicine services over the last couple months, and we've been working very closely with the IT division and Chris Sykes and his team to provide those services there. We have medical assistants that have been hired by our team, that have been trained by our team, that can see patients there on the weekend, that can help with the examination. And we provide consultation notes that go to the primary care doctor after we see them in consultation. We do bill insurance companies, whether they're Medicare, Medicaid, or private insurance companies. And when we do our billing, we put a little GT modifier at the end of that visit, so that's how the insurance company knows that this is a telemedicine service. The specialties that we provide at Millinocket Regional Hospital are neurology, pulmonary, and sleep medicine. This is our referral form, which we'll be mailing out to you, to each of the practice coordinators, referral coordinators, so that you'll have it. If you are seeing this video in a constant contact video, the link to this referral form should be at the bottom of the video as well. And so you can just fill this form out and fax it over to us. Dr. Monimi is our neurologist. Obi is a fantastic neurologist. Our chief medical officer has known and worked with him for many years. Dr. Haval Sadla is our sleep and pulmonary physician as well. They're both physicians in Ohio. We have physicians in Ohio, Massachusetts, New Hampshire, New Jersey, New York. I'm a pulmonary critical care physician myself, and I practice both in Massachusetts and in Maine. The referral form is really pretty self-explanatory, some patient information, some insurance information so we can bill the insurance company, the start and end date of the referral, and the number of visits that you have authorized with the insurance company, the name of the provider who is asking for the referral, and the reason for the referral. And all you have to send is relatively recent office visits, current medication lists, and any relevant diagnostic tests and results. And this is our location at the hospital. It has our fax information as well. You could fax this anytime during the week or weekends, and it'll come to our Kittery location. We are working with the IT team at the hospital to make referrals within the EMR, embedded within the EMR, and as well as helping the hospital to exchange continuity of care documents with us. This is something that we do at Down East Community Hospital, and it helps the hospital meet their meaningful use criteria. And so this way, the EHR can send us data on the patient's current medications, as well as their problem list, and it's really fairly elegant. And so in the future, we'll get those services up and running. Currently, at the end of December, our neurologist is available to see patients, so you can start making referrals immediately to him. He's gotten through the licensing, malpractice, credentialing process. Haval is still getting through the Cinernet credentialing process, but both providers will be sending you out constant contact messages such as this, introducing their new services. But you can start making referrals for both of them now, and we should be seeing neurology patients at the end of December, early January, as soon as we get referrals from the providers at Millinocket Regional Hospital. 3 common questions that we always get. Number one, what if my patient gets sick during the week? If we're only seeing patients through the weekend, does that mean our providers are not available during the week? We have nurses, we have medical assistants that are available during the week. If the patient calls our office in Kittery, we have a great manager named Jane Wyman and a great assistant manager named Quincy, and they're fantastic, and they provide a great deal of support to our patients, and they work with our nurses and our medical assistants to make sure that if a patient with COPD calls in during the week, the provider is contacted, and our nurse can call in medications so that they can stay healthy. So we provide longitudinal outpatient care, not just episodic care. The patient sees the same provider every time they come and see our pulmonologist. They see the same provider every time they see the neurologist, so they develop a longitudinal relationship. Secondly, what if a patient needs a procedure? We've diagnosed patients at Down East Community Hospital with brain tumors. I've diagnosed patients with lung cancer. Our cardiologist has sent patients in for cardiothoracic surgery. So we take ownership of that. So if we're referred one of those issues, we will work with the primary care doctor's practice, let them know that a procedure is necessary. We'll ask them which provider they prefer in Bangor or Portland. We do all the work with getting all the documentation together, making a referral to the specialist, maybe neurosurgeon or cardiothoracic surgeon, and we put together a packet of all their information, and our registered nurse gets all of that information to the surgeon or specialist. So we take ownership of that whole process. So we try to make it easy for the primary care doctor to say that we're going to coordinate with those specialists. So if a patient needs a lung biopsy, or they need an EEG, or they need a service that's not provided here at the hospital, we do that last mile. We make sure the patient gets the care they need. And the last thing I should say is currently we provide, we're providing just neurology, pulmonary, and sleep services at the hospital. But if other services are requested by the primary care providers, by the leadership of the hospital, we really can provide any cognitive specialty that's needed in the area. And finally, what if my patient is older and may not like telemedicine services? I'd say this is a common question that we get from primary care doctors. And I would say that our experience over the last few years has really been that patients, whether they're older or younger, really love the telemedicine service. They hate traveling long distances. If they can stay in their local community, get a test around the corner rather than having to go, drive an hour each way. They really do want to stay local if they can. And even older patients, we found that they're extremely receptive to the service. All patients really get a kick out of the technology, the fact that a doctor can listen to their heart or lungs from 2 states away. So we've really not had any problems with patients not liking the services. And these are actually our patient satisfaction survey results from Down East Community Hospital. These are our last 200 patients, and you can see that all of these questions ease of making an appointment, waiting time to see the provider, courtesy of the staff, knowledge and skills of the physician rank in the outstanding or very good range. And so the patients are very satisfied, with our service. So I hope that this, gives you a glimpse of the services that we're going to provide at the hospital. There will be more videos coming out from our physicians, but please start sending referrals to us, and we can start scheduling patients out. As I said, our neurologist is available to see patients immediately, and we expect our pulmonary and sleep services to be up within the next 1 to 2 months, depending upon credentialing timetable. I hope that was helpful. I would love to meet and speak with any of you. I do come up to Millinocket occasionally to meet with the leadership of the hospital and to deploy the services. And so if any of you would love to meet with me, just let me know. And just call our office, and my staff will set up a time that we can chat. I hope this was helpful, and we look forward to working with all of you at Millinocket Regional Hospital. Thank you.